Welcome everyone to the session, COVID-19 Impact and Opportunities. My name is Lindsay Hebert, and I'm the Associate Director for the Coalition for Global Hepatitis Elimination. I am pleased to be joined today by my co-moderator, Dr. Mohammed Abdulaziz. If you'd like to introduce yourself, please go ahead.
Thank you, Lindsay. My name, like Lindsay said, is Mohammed Abdulaziz. I head the Division of Disease Control and Prevention here at the Africa CDC headquarters in Addis Ababa, and I'm also the acting head of Surveillance and Disease Intelligence. Back to you, Lindsay.
Thank you so much, Dr. Abdulaziz. As all of us on this call know, COVID-19 has changed our lives and the world we live in. Today's session will highlight the inspiring work of partners worldwide to meet this moment, to really understand what the impact of the pandemic has been in terms of disruption of routine hepatitis services, and also exploring the innovations that have led to the maintenance of hepatitis prevention testing and treatment during the pandemic. Furthermore, this session will present examples, and we hope to start a larger conversation how the investments and changes from the pandemic and the response could potentially be leveraged for hepatitis elimination in the future through integration, repurposing of resources, and beginning to reimagine health systems at large. We're really excited for the lineup of presentations we have here. We have an excellent set of country experiences and a roundtable setup. And so we're, I think, ready to get started. Our first presentation today is from Professor Jeff Lazarus from the Barcelona Institute for Global Health, IS Global in Spain. We're also honored to have Dr. Lazarus on our technical advisory board of the coalition. And his presentation is Combined COVID-19 Vaccination and Hepatitis C and HIV screening for high-risk populations in Madrid.
Thank you for the opportunity to present our study, Combined COVID-19 Vaccination and Hepatitis C virus and HIV screening interventions for high-risk populations at a mobile testing unit in Madrid. I'd like to acknowledge all of my co-authors. The background for this study is that, as we know, the COVID-19 pandemic has hindered efforts to address HCV and HIV by reducing testing. And this has happened particularly in marginalized groups, such as homeless people, those with substance use disorders, and refugees and migrants. These individuals, as we know, have some of the highest rates of HCV and HIV and the lowest rates of COVID-19 vaccination. That's why we, as a part of a pilot study, aim to explore the acceptability of combining HCV point-of-care testing with COVID-19 vaccination in a mobile testing unit in Madrid. You see it here on the bottom left. In September and October last year, 101 individuals from high-risk populations were offered a COVID-19 vaccine along with HCV antibody screening. If HCV antibody positive, they were offered HCV RNA point-of-care testing. Everyone was screened for HIV as per the standard of care, and HCV RNA and HIV positive patients not on antiretroviral therapy were offered linkage to care. Of the 101 participants, just over 69% were male, just under a third were of Spanish origin, and most reported having a precarious living situation or being homeless, being unemployed, having a substance use disorder. 28.7% reported having a history of incarceration, almost 18% reported multimorbidity, almost 12% reported having a previous COVID-19 diagnosis, and none of them had been vaccinated for COVID-19. All received the Janssen vaccine without any identified adverse events. Of the 101 participants, all were tested for HCV antibodies, and almost 15% were positive. They were tested for HIV, and almost 9% were positive. And of those HCV antibody positive, all were tested for HCV RNA, and 60% were positive, of which most reported that the most likely route of transmission was injecting drug use. 44% were probable reinfection cases. A third were HIV co-infected. Of those HIV positive, none were new diagnoses. Most had abandoned antiretroviral therapy. And to date, 2/3 have started treatment for hepatitis C, and 1 has restarted for antiretroviral therapy. The duration between positive HIV diagnosis and ART reination for the latter was 25 days, and the average duration between positive HCV RNA diagnosis and treatment initiation was 41 days. The average duration of the mobile Testing unit intervention was 20 minutes. So what did this tell us? It tells us that we can combine interventions. And when we did, there was a 100% acceptability rate. It was also considered safe. And this approach optimized the use of participants' time and the health system's time, as the participants were vaccinated during the time that they would have been waiting for HCV/HIV rapid test results, and it prevented the need for multiple visits. This approach can serve as an example of a novel model of care to couple HCV as well as HIV screening and linkage to care to COVID-19 vaccination in high-risk populations. Next steps include continuing treatment initiation and monitoring. We'd like to acknowledge support from AbbVie to carry out this study. Thank you.
So much, Professor Lazarus, for kicking off the session so well. What an excellent example of an opportunity to expand hepatitis C testing during the pandemic. For our next presentation, we're going to move to the United States, and we have Dr. Dan Saltman from the Hawaii Learning Group to talk about enhancing inter-island hepatitis C care networks in Hawaii with Project ECHO during COVID-19. Dr. Saltman?
Should be a video. Oh, there we go. Aloha, my name is Dan Saltman from the University of Hawaii, joining you from Honolulu, Hawaii today. Thank you for joining us to talk on enhancing inter-island hepatitis C care networks in Hawaii with the Project ECHO program during COVID-19. I'd like to thank my partners in this work, Hawaii Health and Harm Reduction Center and Hep Free Hawaii. Today, I'm going to talk about hepatitis C, Project ECHO, a hepatitis-centered ECHO program, and what I think it all means. 1% of all adults have hepatitis C infection. In Hawaii, that's over 14,000 people. Hawaii has the highest rate of liver cancer per capita in the United States, largely because of hepatitis B and C. There are several direct-acting hepatitis C antiviral treatments on the market now, and they cure more than 95% of people taking them for 8 to 12 weeks in pill form with low side effects. Here's a picture of us in the Pacific, a very small island. And this is part of our statewide efforts to eliminate hepatitis in Hawaii by 2030. The ECHO work falls under the elimination priorities for data, for education, and for access to services. So what's Project ECHO? It's a methodology for sharing knowledge. It started in New Mexico, where the need for the specialty knowledge of a hepatologist was greater than his capacity for delivering it. He partnered with rural health centers and did a careful study that showed that for complex hepatitis care, when the treatment was interferon and ribavirin, that the outcomes at the spoke sites were as good as those at the academic medical center. He published in the New England Journal, and it's been very effective and popular since then. How did he do this? He leveraged technology using video conferencing back before it was popular. And one of the consequences of the COVID-19 pandemic was that people were driven towards using video conferencing, and they understood it much better. And the barrier for doing that, for participating in that way, was much lower. So we got a lot of good participation. The ECHO model is to leverage technology, to promote best practices, to prioritize case-based learning, and to measure outcomes. And how is this different than telemedicine? Is that telemedicine typically is a specialist working with a single patient. In this case, this is an expert hub team that mentors and supports and helps guide the practice of primary care teams in specialty care. We like to talk about moving knowledge instead of people. So this is, as I say, popular all over the world, especially in North America, parts of Africa, and South Asia. Our program was at the beginning of last year for 16 weeks about hepatitis and liver health. I like to start at the end with the outcomes, and the outcomes for education and self-efficacy are a little easier to get at. Outcomes for clinical measures are a little harder to get to, and cost-saving measures are so important, also can be a little more challenging to get to. We started with a case presentation form, and this form also served as the template for people to prescribe direct-acting hepatitis C antiviral medicine. This met the requirements for prior authorization in the state. We developed a curriculum that covered the territory that was needed for evaluation and treatment of hepatitis C and the intersectionality with that patient population. We have an agenda every week that has to do with the case presentations, getting 40 minutes of time allotted, and the question and answer and the didactic having 30 minutes allotted time. And these were continuing medical education approved at no cost to the participants. We'd send out twice a week invitations, once during the week and then once the day of. And in the invitation, we'd relay some news and talk about how to get the CME, how to use Zoom, how to present cases. And then we had a weekly evaluation forms that followed these. And the weekly forms tended to be more for the continuing education requirements, but we looked specifically about whether the didactics increased knowledge and ability and confidence in managing liver disease. And we also looked at whether the case presentations increased knowledge and ability and confidence to care for liver disease. And then there's a quarterly evaluation that was very important that looked at important questions like, did the participation result in a reduced need for travel for their patients? And self-efficacy, that people felt more confident, more capable of being able to take care of hepatitis B and C. And also about working with other specialties, whether it improved their ability to understand what was going on in other domains than than their own, which can sometimes be siloed in healthcare. So we had good participation, about 21 people per session, 20 case discussions. It was a group effort on the faculty part that was excellent, and there was a lot of CME credits earned. Of note, we didn't aim for a wide open invitation. We aimed for a cohort that was going to show up over and over again. And in fact, that's what happened. We had 47 people total over the course, but 18 of those participated in 10 or more sessions. And they were doctors and nurses and pharmacists and other people on the healthcare teams. They came from zip codes across the state, especially from community health centers, and especially from the Big Island of Hawaii over here and from the population center on Oahu. In the end, 10 of those 13 people who participated said that their participation reduced the need for travel for their patient. 8 of the 13 said their prescribing practice would change, and 7 of the 13 said that their referral pattern will change. We got great feedback from people, and I talked about the same things, and I'm going to give you a chance to read about these important conclusions at your leisure. Thank you very much for listening. It's hard to get it in 7 minutes, but please, I look forward to your question and answer. Thank you.
Thank you to the presenter. We've had 2 excellent presentations. So we go to the third presentation, which is going to be from Razin Ashraf Hussain. It's going to be on COVID-19 impact and response on hepatitis B virus and hepatitis C virus prevention and care in Japan. Over to you, Mr. Razin.
Thank you, Honorable Chair. It's my honor to give a presentation on COVID-19 impact and response on hepatitis B virus and hepatitis C virus prevention and care in Japan. I am Mohammad Razin Ashraf Hussain. Here is other co-authors of this study. There is no COI regarding this presentation and study. Background and aim. Achieving hepatitis B virus and hepatitis C virus elimination requires continuous and sustaining high volume of diagnosis and treatment. The Task Force for Global Health Coalition for Global Hepatitis Elimination in 2020 conducted a global survey about the interruption of preventive care and testing of HPV and HCV due to ongoing COVID-19 pandemic. The survey resulted in decrease in HPV and HCV prevention, screening, testing, treatment, and slowing the progress towards hepatitis elimination goal. This study aimed to assess the impact and response of COVID-19 on hepatitis prevention and treatment in Japan by a nationwide survey. This international joint research was conducted by research groups of Ministry of Health, Labor, and Welfare of Japan with the Task Force for Global Health and in cooperation with Japan Society of Hepatology. Study method. We have conducted a cross-sectional questionnaire survey among the medical doctors, including the member of Japan Society of Hepatology. The survey media was online platform Microsoft Forms. The questionnaire was both in Japanese and English language. The questionnaire was disseminated by Japan Society of Hepatology. The survey period was August 2021 to October 2021. In the questionnaire survey, we have addressed 5 different areas: basic information, HPV and HCV related services, challenges and mitigation strategies, doctor's response to COVID-19, and potential benefits on COVID-19 response. Results. Total 196 hepatologists has been participated in our questionnaire survey from the 35 different prefectures of Japan. Among participated medical doctors, 52.6% medical doctors were affiliated from university hospital, followed by public hospital 27.6%. From the participated medical doctors, about 50% of them belong to managerial position on their affiliated institution. About supply chain disruption, there was no supply chain disruption reported related to HPV and HCV. However, 19% of medical doctors responded on mask, disinfection equipment, PPE, supply chain disruption during COVID-19 period. About hepatitis-related services, HPV and HCV screening and confirmatory testing were highly affected by COVID-19 then treatment initiation and patient monitoring. Respondent participants mostly reported 1 to 25% decreases on screening and confirmatory testing. About differing diagnosis and other services, imaging, lab testing were highly differed during COVID-19 pandemic. However, gastrointestinal endoscopy was the most affected during COVID-19 pandemic. In addition with this, most of the hepatologists responded on extended the interval between hospital visits. To back pre-COVID-19 level, there are several challenges reported by the hepatologists: patient anxiety and fear, loss of staff to the COVID-19 response, limited staff availability, loss of clinic space due to COVID-19 were the mostly reported challenge as to resume services to pre-COVID-19 levels. As a part of mitigation strategies, most of the doctors pick audio call as mostly use telemedicine. Besides telemedicine, other mitigation strategies were adopted by the hepatologists, such as extension of prescription period referred to family doctors. On the result of response on COVID-19, most of the medical doctors reported about the changes on infection control among the staff. The reported changes were face masks required of patients routinely assessed about the fever via phone or on arrival, increased wearing mask during patient encounter. Most of the medical doctors reported on providing care related to COVID-19 patients. Their doctor's role during providing care were SARS-CoV-2 testing, COVID-19 vaccination, consultation on liver or infectious disease control management. Despite of so many damages and losses, there are several perceived potential benefits of COVID-19 had reported. As benefits related to hepatitis, such as strengthening general healthcare system, demonstration of value of hepatitis infrastructure, improvement training in infectious disease management. In conclusion, in Japan, a greater decline was observed in HPV and HCV screening and confirmatory testing than for treatment initiation. Anxiety and fear among patients of COVID-19 infection and loss of staff and facilities on response of COVID-19 may be major challenges to overcome this situation. However, immediate action is required to address this trend and return HPV and HCV screening and confirmatory testing back to pre-COVID-19 levels. Besides, efforts should be made to leverage possible benefits of the COVID-19 response to the National Hepatitis Program, including a strengthened healthcare system and demonstration of the value of hepatitis infrastructure for the pandemic response. To achieve HPV and HCV elimination by Hepat 2030, Japan must rebound from the setback caused by the COVID-19 pandemic. Thank you for listening. If you have any questions or comments, please feel free to ask.
Thank you, Mr. Razin. We go to our final presentation for the day before we go to the Q&A session. And this will be taken by Maria Donatelli Klinger from France. And she'll be telling us about complementarity between community HCV care and healthcare services in the time of COVID-19. Over to you, Maria.
Good afternoon, and thanks to the World Hepatitis Alliance for organizing such an important event and for having me here today to speak on behalf of Coalition Plus and its partners. Today, I will present to you how Coalition Plus and its partners reacted to the health crisis generated by the COVID-19 pandemic in order to avoid important setbacks in the fight against hepatitis C and in the achievement of the 2030 elimination target. As in May 2020, most countries started experiencing the devastating effects of COVID-19, marginalized people all over the world were facing the pandemic without being able to protect themselves from it. Confinement was not possible for those who didn't have a shelter and for those who were forced to go out to survive. The poor living condition, the structural weaknesses of a health system, and the blatant lack of basic equipment were all vulnerabilities for which the mobilization of governments soon proved not to be enough. In all countries, but in the poorer more than ever, people continue to die from the ravages of other diseases like hepatitis C, which were more difficult to fight in this time of crisis. It is in this context that community care services became even more needed and important. And it is in this context that Coalition Plus decided to set up an emergency fund to ensure the continuum of care for its population by helping local organizations to maintain HCV services for people living with HCV and other key populations during the COVID-19 crisis. This fund was supported by UNITED. From April 2020 to December 2020, the Emergency Fund allowed to provide services to prevent the increase of HCV and COVID-19 infections among key populations, the maintenance of a minimum activity package of psychological support services and therapeutic care for people living with HCV and people who inject drugs, response to basic needs such as food and economic support, and we were also able to provide personal protection equipment to the community workers that were implementing these activities. This was possible to be implemented in 5 countries where Coalition Plus was implementing its HCV project. Brazil, in collaboration with FOAESP, Morocco in collaboration with the ALCS, Malaysia with MAC and MTAG, India with the MPA Plus and Con Manipur, and Colombia with ePharma and Temeride. Thanks to UNITED, Coalition Plus was able to disburse $263,000 between April and December 2020, and this helped achieving the following results. About 9,700 individuals benefited from community prevention care. 21,000 individuals benefited from social support services. And finally, 6,000 individuals received assistance kits. All these activities and efforts are documented in a short documentary that is available on the YouTube channel of Coalition Plus. The documentary is titled "A Virus Won't Stop Us." If we look into the details of these activities that were funded, we will see that thanks to the activity of local community-based organizations that were quick to step up their game and start facing the new challenges due to the COVID-19 pandemic, while still addressing the old challenges linked to HCV elimination among key population. It is important to show how governments were more and more eager to collaborate with civil society and communities. And this collaboration took the form of the following activities: the maintenance of methadone distribution by communities in Morocco, Malaysia, India, and Colombia, HCV testing in Manipur via community screening, delivery of medication to patients not able to continue their treatment due to the lockdown measures and avoid HIV, HBV, and HCV treatment failure, and then the creation of shelters for drug users in Delhi and Manipur. In a period where hepatitis C was no longer a priority, treatment centers were transformed in COVID centers, harm reduction services were limited, HCV testings were suspended, the emergency fund helped community-based organizations to step in and prove the importance of community HCV care as a complementary health system to the national healthcare services. In addition to this, the burden on health services generated by the COVID-19 pandemic has shown the need for governments to collaborate more with community, the need for simplification of services, the need for the centralization of services in order to minimize the impact of COVID-19 crisis and other future crises on the advancement towards global goals for hepatitis C elimination. As I have a few minutes left, I would like to show you the faces of the people who were at the forefront of this fight.
Hola, mi nombre es María Angélica Jiménez. Hi, my name is Edson.
Mi nombre es Hugo Castro.
My name is Evatlo.
My name is Petra.
Hi, my name is Sunita.
Hello there, my name is Jeremy.
My name is Kurben Dante.
Thank you for listening to this presentation. Thanks to all the partners that were involved in this project and to the community workers that helped fighting both HCV and COVID-19. And finally, thanks to United for the financial contribution.
Thank you, Maria, for the presentation. We've listened to 4 excellent presentations on how to maximize the opportunities created by COVID-19 pandemic, and many highlighted how to overcome the barrier that came with the pandemic. So we now go to question and answer, and to start that, I will be going to Dr. Saltzman from Hawaii, where you use the Project ECHO to improve the networking among health workers in that island. I know here in Africa, at the Africa CDC, We used Project ECHO to improve networking within the regional economic community of the continents so as to improve pandemic and outbreak response preparedness among this. So, Dr. Saltman, a question for you from one of the participants. What are the plans for continuing or expanding the ECHO projects in Hawaii, I believe?
We have a plan to another 16-week series that's more focused on hepatitis B that'll be upcoming starting in August. And that's being funded by the Department of Health. Funding is a challenge for the ECHO programs all across the United States, and it's very heterogeneous. Some of them are funded by state legislatures in large amounts. Some of them are grant funded. The ideal situation is that they become situated in an academic medical center with a budget line that supports them continuously. And in Hawaii, it's a unique situation because the academic medical center is more community based. So it has a smaller faculty, core faculty, and a larger community faculty. So the specialists are largely outside of the medical center itself. So sustainability is always a challenge. That's one of the things that we are continually looking at. And I think as we keep doing it, people understand the value of it better and better. And of course, we're trying to get the word out about the successes of the program so that it garners more support over time. I should say that in the United States too, with the insurance model, the programs like ECHO have a great opportunity to close the gaps in their services, and so they have a direct interest in supporting it themselves, and so that there actually is some movement towards getting the third-party payers, the insurance companies, in particular Medicaid, which is a state and federal combined paying system, to support ECHO-like programs to increase the capacity for specialty care. Thank you.
Thank you, Dr. Saltman. Let me say that sustainability is always important and an issue for a very impactful program like the Project ECHO. So at this junction, I will hand over back to my co-chair, Dr. Lindsay. Please take over the rest of the Q&A. Thank you.
So much, Dr. Abdulaziz, and thank you again to our wonderful presenters. Your work is very inspiring to keep the momentum up for hepatitis elimination during the very difficult 2 years. Our next question is for Maria from our last presentation. It would be wonderful if you could expand a little more on what innovations you saw the community organizations implement that you believe should be continued and expanded on for routine program delivery in the future.
I think that the innovation was mainly the fact that the government really trusted the community to do things that were not allowed to do before. They found themselves in a crisis where the health system couldn't handle everything. And because everybody was so focused on COVID, there were other things that were falling through the cracks, like, for example, methadone delivery or even the delivery of treatment. And so the community just asked the government to do it in their place. And so they were able to have special agreement to be able to go out during lockdown and deliver the treatment themselves, especially to the people that were away from the medical centers. So there was a sort of decentralization that before wasn't really accepted, and it showed that it worked. And the other thing is that they also developed new models. For example, In India, where our partners found themselves to deal with the fact that drug users were not allowed to stay in the streets, even though they were homeless, and so they were facing some police brutality, created some centers, some shelters that allowed people to continue their treatment, to get tested if they weren't tested before, and to initiate treatment while there and while also receiving harm reduction services.
Really terrific, and I think such important lessons for all of us to hear and advocate for to as we move forward, making sure those aren't just emergency implementation strategies, but really become the standard, because they're so critical, I think, to our success. Thank you, Maria, for sharing that. All right, I think our next question is for Razine from Hiroshima University. This question is, what do you believe are the main differences in the experience in Japan in terms of impact of COVID on hepatitis programs compared to the global survey results?
Thank you, Lindsay Sensei. Before answering your question, good evening to everyone, because in Japan it's almost 10:30. So, and before answering this question, I would like to acknowledge that Honorable Chair Lindsay Sensei is one of the integral part of this survey. So, and also global survey. So in Japan study, what the significant difference we see in that the decreased level in hepatitis B virus and C virus for screening and for treatment is more or less 1 to 25%, which is much less than global survey in other countries. But this main scenario is here, the main problem is most of the doctors reported that there is a patient anxiety and fear. It is more than 60%, about 70%. So it is a big challenges to make them again into the treatment and diagnosis. So it is the main challenges and main difference I have seen at the global survey and in Japan. Thank you.
I have two more questions, one more for Dr. Saltman and then one for everyone in the group. For Dr. Saltman, and the Q&A came in, do you have any advice for others who want to implement the model you described, the ECHO model?
Oh, good. It'll be easier to say it than it was to type it in there. Yes, it's really, there's a couple things that make this very different, that make the ECHO model very different from webinars. One of them is the emphasis on case presentations, so that you encourage people, you make that the priority and the primary thing rather than the didactic part or the lecture didactic part. And by focusing on the cases, people start to talk about real patients, their real experience, and their real work in a facilitated environment that is very exciting and very different than many medical education experiences that people have. And one of the this is a pearl. One of the things that makes those case discussions more effective is to advise your expert hub team to separate the recommendations, to delay talking about recommendations from allowing people to discuss the background of the case first, because the experts are always ready to sort of jump in and sort of go right to the end to say what their recommendations are. But you increase the opportunity for this community building among the providers and among this interdisciplinary team if the facilitation allows for a discussion of the background, the history, the physical exam, questions about that, questions of the social environment that people come from, and then summarize that and then go on to the recommendations. That improves the strength of the case presentation aspect of it. So a little bit of coaching for your expert team to do that goes a long way. And that helps the facilitation. It's very different than a webinar. When it's done right, it's not a webinar. It's not a lecture. It's really this kind of community discussion in an interdisciplinary, collaborative way. That's when it's happening, it's exciting and everybody knows it. So that's my two cents on that. Thank you.
Wonderful. Thank you, Dr. Saltman, for sharing that wisdom. So our last question for this session, thank you everyone for joining and contributing your very insightful thoughts to, I think that's the beginning of a broader conversation of how we move forward from COVID-19 and get back on track for hepatitis elimination. So the last question really is, do you have any final advice for the hepatitis community at large about how we can really advocate for dissemination of these best practices and innovations? The question in the chat was, do you think a UN General Assembly commitment would help this issue in terms of gathering funding for maintaining these innovations? But if you have other suggestions as well, we open that. And Dr. Abdulaziz, I might start with you and share your experience from Africa CDC, please.
Thank you, Lindsay. Really, for us, we were able to see that focusing on ensuring that what is done to control a pandemic or an outbreak does not disrupt the supply chain, especially for a continent like Africa that depends on a lot from being brought in from outside the continent. And also opening up humanitarian corridors to ensure that supplies for diseases that require continuous medication and diagnoses and all is able to, supplies are able to get to the most vulnerable section of the population. But most critically for the African continent, we've come to realize that we need to support local manufacturing of consumables like diagnostics, like vaccines, like infection prevention and control materials. So all this is now the focus of what we call the new public health order for Africa, being championed by the African Union and Africa CDC. Thank you. Back to you, Lindsay.
Thank you so much. Maria?
I have 2 points I would like to make. First, the other day I heard Peter Sands saying something that was very interesting. He said, it's fine to talk about preparedness, but let's not forget that we have pandemics today and people are still dying of these pandemics. So let's talk about preparedness, but let's not forget that we need to save lives today. And we shouldn't worry too much. We should worry, but not only about the diseases of the future. So I think this is the first thing. Let's continue to work to fight hepatitis, HIV, and let's not forget. And there is a little bit here with COVID coming. The other thing is that I really think that, I said before, communities showed that they must be an actor in response, and they should be recognized as a valuable complementary system to the traditional healthcare services. And so donors should start taking that into account, because even communities need to eat. And so I think that peer workers should be recognized as a clear profession that should be receive the right compensation. And the last thing that I wanted to say is that probably I'm not sure if a UNGA resolution would be the way to go, especially because it's not binding, but definitely it could help to raise the issue again in international fora. I have the feeling that we're talking a lot about preparedness and COVID, and we're not talking about the great pandemics that we're living nowadays. Thank you.
Thank you so much, Maria. Well, Razine, and then Dr. Saltman, if you want to close us out today.
Thank you, Chair. So, Dr. Saltman, you want to start, or it's okay? Okay. Thank you very much. So COVID-19 has impacted on hepatitis, that is for sure, and there is no doubt. Even if it is 1%, still it is an additional burden. So we cannot change what happened or how much hampered has done by COVID-19 on hepatitis. Still a lot to do from day before yesterday and yesterday's session. What I can sum up that still $1 trillion is shortage in hepatitis fund, and COVID-19 beside made some more gaps. So however, COVID-19 has given us several lessons to do things in future. Additional several things improved, such as focus on infectious disease control and prevention, and strengthen general healthcare system, improve laboratory testing, contact tracing, and so on. So 2030 is not so far, but not so near. So there might other pandemic come, or I hope it's not, but we have to be prepared for any kind of challenge. And I hope not such pandemic comes in future. And but this time, I think if it happened, our hepatologist and the system is now slightly cope up with the situation, and we all have to move forward, not to changing our target, rather keeping the same target, eliminating hepatitis by 2030. We have to move forward with additional advantage and gaps. That's all I think. Thank you.
Thank you. It's a daunting problem, and healthcare is a big sprawling thing. Treating hepatitis C changed my practice and changed my life. You know, never before could we cure a chronic disease, and I think hepatitis C is really an excellent model for focusing. You know, one of our partner, the Hep Free Hawaii group, they have sort of focused on multiple aspects of it, micro elimination projects, and sort of chipping away at the parts of it that are manageable. And one of the things that's so good about hepatitis C as a disease condition is that the definitions are very clear. The diagnosis is clear, the treatment pattern is clear, the follow-up is clear. It's really it's a lot easier than, say, diabetes, for instance, or hepatitis. I don't know if I should say that at this forum. Hepatitis B is a lot more complicated. It's kind of a longer term proposition with the current treatments. But hepatitis C is a curable disease. So it's kind of, you can, in an island state like Hawaii, you can know the extent of it in theory. You can know who's infected. You can try to deliver, the issue then becomes the cost of the medicines. But it's a knowable quantity. And so that makes it a curable condition, and it makes elimination a real thing. It's not just pie in the sky. You can really eliminate and get rid of, getting rid of, which means reducing it to 10% or 20% prevalence kind of thing. It's realistic. It's practical. So it's really a possible thing to do. And by focusing on that, I think it points to how the medical system in your locale has to work in order to achieve that goal. So I love pursuing it as a purpose that people can really get around together in order to define what the issues are in a complicated medical system.
Thank you all for those final thoughts. And I think that's a great way to close our common purpose, why we're all here. So I really appreciate, on a personal level, everything you all did to continue hepatitis services for those most affected during the pandemic. I think that it's just really inspiring case studies we heard today. And just a short plug, the coalition is currently collecting case studies and examples. So I'll certainly be reaching out to our presenters to get more information on your projects. We really would like to put together a compendium of what happened during COVID-19. What are the lessons learned, and how can we make sure to build on the past few years as we move forward, both in terms of preparing for the next pandemic so we don't see the same disruption in services, but also really making sure we capitalize on these investments and these innovations that we've seen during a really extraordinary time, I think, in our world. So We hope to be in touch with all of you. If anyone in the audience also has case studies and examples, please reach out to us. We'd love to hear from you. So I want to thank the presenters again for your talks today. They were excellent, and please join the next World Hepatitis Summit session. Take care, everyone. And thank you, Dr. Abdulaziz, for co-moderating with me.